And our second semi-finalist is Dr. Marian Polly. She will be talking on outcomes of patients undergoing orbitotomy in cavernous venous malformations. Over to you.
Thank you. My paper is on functional outcome in patients undergoing orbitotomy for cavernous venous malformation, no financial interest. As we know, cavernous hemangioma is a simple venous malformation seen in middle-aged females, and excisional biopsy remains the treatment of choice. However, there is a wide discrepancy in the management as visual impairment can occur due to surgery itself in 2 to 24% of cases. So in this context, we did a study to analyze the functional outcome in patients undergoing surgery for cavernous hemangiomas. It was a retrospective interventional study of 8 years in a tertiary care center. Detailed history of ophthalmic evaluation, imaging, and orbital volume was calculated in all the cases. Surgical approach was determined based on the location of the tumor. Stellar right incision or Burkitt's incision was used. Cryo-assisted tumor removal was done in all the cases. Muscle disinsertion and reinsertion was done in selected cases. Pupil was monitored throughout the surgery. Those patients with a 6 months follow-up were included, and those referred for revision surgery and extracorneal location were excluded. Patient was admitted for 1 day and discharged next day, then followed up at 1 week, 1 month, 6 months, and yearly thereafter. Refraction was done, color vision, visual fields, and OCT was done in patients with subnormal vision. The main outcome measures were changes in visual acuity and refractive error, ophthalmoscopic changes, and complications related to surgery. Coming to results, we had 10 eyes of 10 patients with a mean age of 44 years with a follow-up of 21.8 months, females outnumbered males. Proptosis was the most common presenting symptom. Color vision was normal in all the patients pre and post-op. Visual fields were also normal in 9 patients, one had central scotoma. Coming to ophthalmoscopic features, hyperemic disc and disc edema was present in 2, it was disappeared post-operatively. Chororetinal folds were present in 4, it persisted in the post-op. Serous macular detachment was present in 1, it persisted post-op. Less than 6 by 18 or equal to was present in 1 patient, which was improved in the postoperative period. All other patients had good vision pre and post-op. Coming to the changes in hypermetropia was present in 70% with ranging from plus 0.5 diopters to 5 diopters, of which 4 eyes had more than or equal to 2 diopters. In the postoperative period, 5 had persistent hypermetropia, and the average reduction in hypermetropia was 33.6% only. CT scan was done in all the cases. The horizontal dimension ranged from 1.4 to 2.9 millimeters, and the tumor volume from 2.1 to 7.6 ml. Infralateral was the most common location. Lateral orbitotomy alone was done in 7 cases. Lid split was in 1, and combined approach of lateral orbitotomy with the lid split was in 2 cases. Medial rectus disinsertion was done in 1 patient. Coming to the complication, 1 patient had tonic pupil and 1 had late in ophthalmos. This is my index case, pre of hypermetropia, did well with following surgery. So discussion, this is a unique study of 10 patients where dual approach was used in 2 patients of cavernous hemangiomas. None of them had any loss of vision. If you see the visual impairment following excision of cavernous hemangiomas, there is a reduction in visual acuity of 3 to 32% in 3 to 32%, and there is no light perception was reported in 1.2 to 4.2%. It can occur due to CRIO as well as optic nerve ischemia. In our series, all patients are good preoperative vision, and we use dual approach and muscle descent in 1 case. 70% had hypermetropia, only 33.6% reduction in hypermetropia. Harris et al. Noted 75% of preoperative hypermetropia was retained in spite of complete tumor removal. Scleral fibrosis and remodeling with chronic distortion can lead to permanent scleral deformation, and permanent change in axial length could be the reason. 40% had choroidal folds. The choroidal folds persisted even though the height has been reduced. The reported incidence is 14 to 41%. In our series, all were intracorneal masses. And long-standing choroidal folds can lead to RP hypertrophy and later atrophy. Complications, 1 had tonic pupil, but she was asymptomatic. It occurs due to the injury to the short ciliary nerve or ciliary ganglion. Coming to limitations, this was a small sample size. So what this study yards, functional outcome following orbitotomy for cavernous hemangioma remains excellent with careful surgical technique, proper selection of surgical procedure, and careful intraoperative dissection. 2 surgical approaches can be combined if the tumor is at risk for loss of vision. Post-op recovery depends on the preoperative findings. Smaller tumors, small refractive errors, favorable parameters. Large tumors causing globe indentation can lead to persistent choroidal folds. So we propose early surgical intervention in symptomatic intracorneal cavernous venous malformation. Persistence of choroidal folds in the postoperative period needs further research. These are my references. Thank you.
You have 10 patients, na?
Yeah.
Just a suggestion, a subgroup analysis, you have dimensions of all the tumors and you have hypermetropia degree also. So somehow you can correlate with the how much is the dimension, how the extent, how much it will be the hypermetropia. Some
Yeah,
subgroup
actually,
analysis, it will be a
yeah, actually I
add
have
on.
done tumor time only 5 minutes, no, so that is why I didn't present
Okay.
subgroup analysis.
Yeah, that's
Yeah. Thank you so much.
Yeah, hi. So,
No? You're too kind a person. So just first of all, compliments on using the term cavernous venous malformation, because I still am listening and to various talks, including experts who still calling it cavernous hemangioma. So compliments on that.
Thank you.
You made a statement saying that early intervention for symptomatic lesions. How would you manage an asymptomatic lesion? Number one. Number two, incidental cases, right? We do see them. And what is your opinion regarding conservative management with intralesional sclerotherapy, given the fact that these are malformations? So I'm sorry, I have to ask her tough questions.
Asymptomatic in the sense when the patient just presents with proptosis, vision, fields, color vision, everything must be normal at that point.
I mean asymptomatic is they end up having a CT scan for something else. Have you had patients refer to you with incidental lesions? So those are the asymptomatic ones, no proptosis.
All had proptosis. One patient presented with orbital pain. She didn't realize that she has got proptosis, but all had proptosis. So she was
What would you recommend
I recommend
to the people in the audience who know less than you?
no. If I personally feel if there is a cavernous hemangioma, it usually slowly growing, and later on it can lead to all the globe deformation, etc., choroidal folds. So if we can intervene early, that's what I feel, so that safe. Because in my series, one patient was keeping the hemangioma for almost 7 years, and he developed choroidal folds, and the fold was persisting even after 1 year of follow-up. So the vision was only 6/12, even at 1 year follow-up. So before that, I think we can intervene. Then sclerotherapy, I don't think, because this is a small venous malformation, so I don't recommend, because it is complete removal. If it is a very posterior, it can cause threaten to the vision, but still sclerotherapy also can cause loss of vision. So if it is surgically amenable, better to remove it surgically, or we can use stereotactic radiation
Thank you
rather
very
than
much.
sclerotherapy.
Thank you. Great case. Great presentation.